Following an incubation period of weeks to months, cutaneous leishmaniasis may develop on skin exposed to sandfly bites. Cutaneous leishmaniasis has a variety of different presentations, depending on the species involved, but generally it begins as an expanding, pink-colored papule that eventually develops central softening and gradual painless ulceration. These skin lesions gradually heal into a depressed scar or keloid over the course of months to years and may reactivate if left untreated. Additionally, mucosal involvement may occur, particularly in immunocompromised hosts and by the New World species. Symptoms can include nasal congestion, cough, hoarseness, odynophagia, and mucosal bleeding. Severe cases may result in significant pain, inflammation, and deformity from erosion and destruction of surrounding tissues. Following an incubation period of months, visceral leishmaniasis may occur in the form of, quote, Kala-Azar. Kala-Azar is a slowly progressive syndrome of fever, malaise, weight loss, and massive splenomegaly as parasites disseminate within macrophages to the lymph nodes, liver, spleen, and bone marrow. In advanced stages of disease, hepatic dysfunction, ascites, edema, splenic sequestration, bone marrow suppression, hemolysis, and cachexia occur. In South Asia, the skin characteristically darkens, giving rise to the description of, quote, Hala Azar, which means, quote, black fever in Hindi. If left untreated, visceral leishmaniasis is universally fatal. Cutaneous leishmaniasis is definitively diagnosed by skin biopsy and confirmed by either visualizing a mastogotes on histology, growing leishmania in culture, and/or demonstrating leishmania DNA on PCR. Visceral leishmaniasis is definitively diagnosed by either tissue biopsy or aspiration of the spleen, bone marrow, and/or lymph node. Sampling of the spleen has the highest sensitivity of 96%, but it also has the highest risk of serious complications, including splenic hemorrhage or bowel perforation. Sampling of the bone marrow is a safer procedure, but has a lower sensitivity of 70%. Lastly, sampling of the lymph node is the least invasive of the three options, but with the lowest sensitivity of 58%. Serum serologic and urine antigen testing are also available in the diagnosis of visceral leishmaniasis. Certain serologic assays have been shown to have both high sensitivity and specificity, but cannot be used for monitoring treatment response, given that antibodies will remain positive for years after resolution of active infection. Urine antigen assays, on the other hand, are able to monitor treatment response, but have low sensitivity of 70%.